So in the previous lecture, we had talked about some of the pharmacology of hydroxyurea as it pertains to the treatment of sickle cell anemia. So some of the vocabulary words that pertain to pharmacology might be a little gray for some people. And so I made the second half of this lecture really kind of describing a lot of the concepts that were defined in those previous lecture material. So in terms of how hydroxyurea has its effect in terms of cell killing, some drugs, many chemotherapeutic drugs, affect the cell cycle in specific phases. And of course, these phases are defined here. Here's the cell cycle that you probably learned in biology class. So the drugs that have specific cell cycle killing are called cell cycle phase specific drugs, and hydroxyurea is one of those. And earlier we said that hydroxyurea really had its main effect at the S phase, where essentially DNA synthesis, S for synthesis, is starting to occur. Other drugs that are chemotherapeutic in nature may be able to kill certain cancer cells outside of a specific phase, and so these are called cell cycle independent drugs. And just for your knowledge gap, cyclophosphamide is one of those such drugs, and so it doesn't matter which phase the cell cycle is being undergone. Cyclophosphamide will kill the cell no matter what, regardless of that. So that's a little bit background on cell cycle. The other concept that I wanted to define was this concept of LADME. And LADME is a famous pharmacology acronym that really just kind of describes the concept of going from pill to physiologic effect and excretion. Okay, and so LADME stands for liberation, absorption, distribution, metabolism, and excretion. And so earlier we said that hydroxyurea can be given orally or intravenously. And so what's the difference? Well, the main difference is this LADME phase, and then understanding which of these phases is going to be affected by the two different forms of administration, oral and IV. Okay. And so for this drug to have an effect, it has to be active. And so one other concept that I need to kind of bring up is going along this liberation and absorption phase is that when the drug is liberated, it's essentially in a salt form. And so the salt form is essentially inactive. And remember your Henderson-Hasselbalch, and this is the implementation of Henderson-Hasselbalch in terms of pharmacology. If your drug is a weak acid, in this case, basically it exists in an equilibrium. Of course, this is in the gastric compartment, and so the pH is very, very low. It's 1.4, 1.2. Once it crosses that mucosal barrier, then the pH changes from very acidic to only slightly basic. This is part of the absorption phase. And here, the equilibrium shifts, where the salt form is dissociated into its charged forms. And so this charged form of the drug, this A- form, is the form that's biologically active. And so this ionized version of hydroxyurea is actually the thing that produces a physiologic change. And it's the one that has the affinity or the binding to those different mechanisms that we had described earlier. So this is the active form, this ionized form, and this is the form that elicits biological change. Earlier we said that there are two routes to administration, oral and IV. And really the only difference is the amount of time it takes for that administered dose to have an effect. So oral or extravascular, really any of these administrative differences could account for this particular graph. And so any of these routes of administration can produce this slight delay. And so here's the plasma concentration, here's the time, and you see it takes some time for this liberation, absorption, and distribution phases to occur. And so this gap from the x-axis to this portion right here is the time to peak plasma concentration. And so what are you doing at this time? Well, you're essentially waiting for the drug to work. You're waiting for it to be liberated, absorbed, and distributed throughout the different body compartments. And what we're looking at here is the plasma concentration. So this is the amount of time it takes an oral dose to go from the stomach into the bloodstream. And this is in contrast to an intravenous dose or an IV dose, which offers essentially 100% absorption, but no absorption phase. And so here you've got the plasma concentration within a minute or two of injecting the drug. You see very, very high levels of the drug and then a corresponding decline in drug levels. And this is really coming from distribution and elimination of that drug. And so the clinical correlate here would be, why do patients in the ER receive IVs of drugs? And the answer is that, well, the time to peak plasma concentration is very fast. And so if you give a drug IV, the clinical outcome or the clinical benefit is noticed very quickly. And so in terms of emergency medicine, you know, that those 2 minutes can be the difference between life and death for the patient. Both of these concepts in terms of oral versus IV dosing lead to the concept of bioavailability. And really it's translated or defined as the fraction of an extravascularly given drug dose which reaches the systemic circulation. Okay, and so by definition, if a drug is given by mouth, typically it's less than 100% bioavailable because some portion of that drug has to be metabolized or transformed or degraded or changed in some way. And so the things that affect bioavailability are listed here. And all of these things produce a reduction in bioavailability if the drug is given by mouth. If the drug is given by IV, by definition, it's 100% bioavailable because every single portion of the administered dose reaches the systemic circulation because you're injecting it into the systemic circulation. Okay. Now, hydroxyurea is kind of a unique drug in that the oral dose or the oral administration is actually over 90% bioavailable. And so that's kind of unique for oral drugs. And it's also very excellent. And so, you know, in terms of dosing, you know, hydroxyurea versus oral versus IV, there's really no clear benefit to an IV dose, at least kinetic-wise, in terms of the amount of drug that the patient's getting. The real only kind of clinical benefit to IV dosing would be if the patient cannot swallow a tablet for whatever reason. And so that would kind of really be the difference between these two administrations. In terms of pharmacokinetics, it's good to remember that the IV dose does not have a liberation or absorption phase. It's got complete distribution, metabolism, and elimination, whereas the oral dose does indeed have a liberation, absorption, and distribution phase. And so those are the two kind of main differences between how you administer all of these different drugs. Understand too that there are some pre-treatment lab tests that's going to govern whether or not it's safe to use hydroxyurea, and those are listed here. Of course, as the curriculum goes on, you'll learn about the complete blood count, or the CBC, and you'll also talk about the differences in metabolic profiles of renal and liver function tests. And so also, because one of the mechanisms of hydroxyurea includes the induction of fetal hemoglobin, it would also be a good idea to kind of understand what the baseline levels of fetal hemoglobin are, especially if you're going to increase them, because then you can actually see how effective the drug is working. Of course, every drug has its side effect and toxicities. The major side effect and toxicity for hydroxyurea include leukopenia, which is really just low white blood cell counts. And in some patients, the induction of megaloblastic changes in certain immune heme cells. The drug does produce nausea. It can and has produced skin rashes. It also has been known to induce a drug fever upon administration, painful leg ulcers, of course, and this drug should not be given to pregnant women or women who may become pregnant because, of course, it is a teratogen. And so these are kind of the main side effects and toxicities associated with hydroxyurea, and this satisfies learning objective 3, of course. Of course, I understand there are others, but these are kind of the more commonly reported types of toxicities that you can see. So this concludes the lecture for the second half of the lecture for the treatment of sickle cell anemia in the context of using hydroxyurea as kind of a model drug to go through some of these basic pharmacology concepts. Thank you.